Thank you to the organizers for asking me to speak on subclinical hypothyroidism and autoantibodies in fertility and pregnancy loss. I have no conflicts of interest to declare. So what I would like to do today is to review the evidence regarding potential effects of subclinical hypothyroidism with or without thyroid antibodies on fertility, as well as the evidence of potential treatment for subclinical hypothyroidism with or without antibodies on fertility and pregnancy loss. And the reason why we all might be a little bit confused as to what to do with mild hypothyroidism and thyroid autoimmunity in pregnancy is that there are a variety of guidelines out there, which I've just summarized on this slide here, and each of these guidelines will say something slightly different. I also know that there are American Thyroid Association guidelines in development, and I'm on the fertility group, as well as UK guidelines on pregnancy and fertility, and they again may say further slightly different things. But in order to illustrate this, I thought we'll start with a clinical case. So this is a 30-year-old female with unexplained subfertility for 2 years. She has no other past medical history and nothing particularly is found on clinical examination. She has a normal BMI. You can see here her thyroid function test results. So she has a serum TSH of 5.4, a serum free T4 in nanograms per liter, that's 0.9, and she has thyroid antibodies that are undetectable. And so the question is, so this is a lady with a serum TSH of 5.4 and not much else to find, is do we start levothyroxine therapy at 1 to 1.2 micrograms per kilogram? Do we start levothyroxine at 1.6 micrograms per kilogram? Do we give her 50 micrograms of levothyroxine? Do we reassure her and tell her no action is required? Or do we repeat TSH and free T4 measurement in 2 to 3 months? I'll just give you a little moment to think about this. And I will come back to what I think is the right answer at the end of this section. But so subclinical hypothyroidism is known to increase the risk of miscarriage, preterm birth, preeclampsia, and perinatal mortality. And we have known this from a number of systematic reviews, including the one quoted there. The association between subclinical hypothyroidism and subfertility remains conflicting, and there is insufficient evidence to suggest that subclinical hypothyroidism causes subfertility. What we do know is that women with subfertility have higher TSH concentrations, and we know that because we screened 20,000 women with TPO antibodies and their thyroid function test who had normal thyroid function in order to do the tablet trial, and I will come back to this. We also know that high TSH values greater than 5 millunits per liter are associated with lower fertilization rates. There is no association between subclinical hypothyroidism and recurrent pregnancy loss when this is defined by non-consecutive pregnancy losses. However, when you look at an association between consecutive recurrent pregnancy loss and subclinical hypothyroidism, there may be an association. And again, this was a systematic review here that highlighted this. However, when you take all the evidence together, there is no strong or consistent evidence for an association between TSH values of 2.5 to 4 millunits per liter with adverse fertility or pregnancy outcomes. What about treatment then? What happens when we treat subclinical hypothyroidism in patients who come to our fertility clinics? Well, again, most of the evidence here comes from cohort studies and from randomized controlled trials. Cohort studies have found mixed findings. But again, evidence of benefit is only there if TSH is greater than 4 millunits per liter. And similarly, from RCT evidence, again, this would lean more towards treating those patients with a serum TSH over 4 and not for those with a serum TSH between 2.5 and 4. And this is summarized here in this systematic review that was published in 2019. So the top panel here refers to pregnancy loss rate, and the bottom panel is preterm birth rate. Again, this was from mixed population and mixed study type. But you can see that when you look at pregnancy loss rates, treatment with levothyroxine of subclinical hypothyroidism did result in slightly lower pregnancy loss, but it did not prevent preterm birth. So coming back to our case then, I think in this patient who has a serum TSH that's well above 4 and also above the upper limit of normal of the reference assay here, I would start levothyroxine at 1 to 1.2 micrograms per kilogram, and I would aim to keep her serum TSH to less than 2.5 throughout pregnancy. Moving on then to the second clinical case, this is a 35-year-old female who has a history of 3 first trimester miscarriages, and she has no living children. Again, no significant past medical history, but a family history of hypothyroidism. She has had a number of tests for recurrent miscarriage, and all of these are normal. Again, here she has a normal serum TSH at 3.5, a serum free T4, this is given in nanograms per liter, but again, this is within the normal range. And then she has TPO antibodies that are raised at 260. So what we have here is someone with normal thyroid function and raised TPO antibodies. And again, the question here is, which is the most appropriate next step? Do we start levothyroxine and aim for serum TSH to less than 2.5 before she becomes pregnant? Do we reassure her but monitor her thyroid function during the next pregnancy, starting as soon as she becomes pregnant? Do we offer her oral prednisolone, 10 milligrams daily, starting from the next positive pregnancy test? Or do we advise the patient not to get pregnant and repeat her thyroid function test after 3 months to ensure that they are stable? So again, I'll just give you a minute to have a look at this. Okay, so thyroid autoimmunity can be widely defined as the presence of antibodies to thyroid peroxidase, thyroglobulin, or the TSH receptor. And this is the most common autoimmune condition in women of reproductive age. I'm not focusing here on women with positive TSH receptor antibodies. We know that an association has been observed in groups of subfertile women between TPO antibodies and unexplained infertility, endometriosis, and ovarian causes of infertility, such as polycystic ovarian syndrome or premature ovarian insufficiency. However, this is just an association, and causation, again, has been very difficult to prove. There is no difference in ovarian reserve markers when you look at anti-Müllerian hormone, FSH, or other markers between women who are thyroid antibody positive and thyroid antibody negative. And we know that, again, from a large systematic review that was published in 2021. So how common is thyroid autoimmunity? Well, when we screened 20,000 women for the tablet trial, we found an overall prevalence in the United Kingdom of positive TPO antibodies. So these were all women who had at least one miscarriage or unexplained subfertility. And we found an overall prevalence of thyroid TPO antibodies of 9.5%. We found that the odds of being TPO antibody positive increased with age, but that was not statistically significant. We found that Black women were less likely to have positive TPO antibodies compared with white women, and you can see an adjusted odds ratio here. And that this was very much linked to BMI. So women with a higher BMI, certainly those with a BMI that was greater than 35, were much more likely to have TPO antibody positivity. They were not more prevalent in women with subfertility compared to those who had recurrent miscarriage. So what are the effects of thyroid autoimmunity on fertility? Again, a very nice systematic review and meta-analysis of 22 studies published fairly recently found no difference in fertilization rate, implantation rate, and clinical pregnancy rate in women who were TPO antibody positive compared with those who were not. What about the effects of, so that those were the effects on fertility. What about effects on pregnancy outcomes? And again, here a number of large meta-analyses have been done. When you look at the miscarriage rate, this encompassed 21 studies. And again, there was a significantly higher miscarriage rate in women who were TPO antibody positive compared to those who were not. So it appears to be affecting pregnancy outcomes, but less so fertility outcomes. When you looked at live birth rate, again, there was a significantly lower live birth rate in women who were TPO antibody positive compared to those who were not. And then a number of large systematic reviews and IPD meta-analysis again have confirmed this increased risk of miscarriage and preterm birth rate. So there was a study in 2011, which actually formed the basis for the tablet trial, which I'll come back to, as well as Tim Korov's study. So this here illustrates Tim Korov's study. So this is from the Thyroid Consortium, which looked at 19 cohorts of patients who had TPO antibody and thyroid function measured during pregnancy. You can see nearly 50,000 women in here. And what the forest plot illustrates is the association with preterm birth. You can see that in women who were TPO antibody positive, they were more likely to have a preterm birth. And this was particularly linked in those women who had positive TPO antibodies, but also had a serum TSH that was greater than 4. So can we do anything about this? There clearly is a link between TPO antibodies and worse pregnancy outcomes, albeit not fertility outcomes. Is there anything that we can do about it? So there have now been a number of randomized trials, 2 of which I will highlight. There has been the tablet trial that I've been involved in, as well as the T4 Live trial. The original study was done by Roberto Negro, and there's also been a Chinese trial that has looked at treating. So this is women treated with normal thyroid function and positive TPO antibodies who are treated with levothyroxine. So in the tablet trial, we randomized 960 women to receive either levothyroxine or placebo. So these are women, again, normal thyroid function, positive TPO antibodies. The primary outcome was live birth at a minimum of 34 weeks. And this was a negative trial. We did not find any difference giving women with positive TPO antibodies levothyroxine compared to those who received placebo. You can also see that there have been a number of secondary outcomes that have been looked at, whether there were early miscarriages, whether there were stillbirths, whether there were ectopic pregnancy, whether this resulted in termination. None of these found any significant differences. We also did a subgroup analysis, and particularly focusing on a number of factors that appear to be associated with worse pregnancy outcomes. So this included maternal age, the number of miscarriages, their serum TSH concentration, their level of antibodies, as well as their ethnicity. And what I would like to focus on here is the number of miscarriages, as well as the serum TSH concentration at baseline. You can see here that, again, none of these results were significant, so there was no difference in outcomes treating with levothyroxine when you looked at the number of previous miscarriages that women had had. So no difference between those with subfertility compared with those who had 1 or 2, and compared to those who had 3 or more miscarriages. Similarly, and this is really important, the thyrotropin concentration at baseline did not appear to make a difference. So we did not find that treating women with TPO antibodies and a serum TSH that was greater than 2.5 but less than 4 resulted in better outcomes. And again, whether women underwent infertility treatment at time of randomization or not had no particular effect. We then did a further study of those women who had been recruited to the tablet trial, looking at what happened to those women who have normal thyroid function, positive TPO antibodies, but to see if they actually developed thyroid dysfunction. So when we looked at thyroid dysfunction, out of the 940 women randomized, 7.4%, so 70 of those women developed hypothyroidism. This was subclinical in 90% and overt in 10%. We also found that 2% of women developed thyrotoxicosis, and this was particularly unsurprisingly in those women who were treated with levothyroxine. So 18 of the 19 patients who developed thyrotoxicosis had actually undergone levothyroxine treatment. So when those women developed thyroid dysfunction, 80% of them did this within 6 months of entry into the trial, and the majority of them had this done pre-conception. If it occurred during pregnancy, then most of them presented, 85% of them presented at 6 weeks, whereas a small minority presented at a later stage. So it appears that when those women develop thyroid dysfunction, it happens early on in the disease process and happens early on in pregnancy. What were the risk factors? So those women who had higher levels of TPO antibodies and who had higher baseline TSH concentrations were more likely to develop hypothyroidism. Importantly, what we found was that there was a higher failure to conceive rate in women who had treated subclinical or overt hypothyroidism. But importantly, we did not find a significant difference in live birth rate, depending on whether those women developed thyroid dysfunction or not. But what this study nicely illustrates here is what happens to those women who have positive thyroid antibodies and who have normal thyroid function, indicating that it will be important to monitor their thyroid function once they become pregnant and probably before they become pregnant. More recently then, following on from the tablet trial, the T4 Live trial was performed in the Netherlands, and the results were published in 2022. So this is 187 women who have a history of recurrent pregnancy loss, and this was defined as 2 or more losses. 50% of them were assigned to receive levothyroxine, and 50% were assigned to receive placebo. Their primary outcome was live birth, and there was no difference in the primary outcome. So you can see here that 50% of those and 48%, 50% of those in the levothyroxine group and 48% in the placebo group had live birth. And they had non-significant risk ratios and absolute risk differences between the two groups. So again, a further trial that indicates that treatment of levothyroxine in women who have normal thyroid function and positive thyroid antibodies results in better pregnancy outcomes. So what is the current research that's ongoing in the field? Well, the previous iteration of the ATA guidelines states that levothyroxine therapy may be considered in those women who are TPO antibody positive and who have serum concentrations greater than 2.5, or so between 2.5 and the lower limit of the pregnancy-specific reference range, which is usually 4. This recommendation predated all 3 of the largest clinical trials, and therefore it is unlikely that this recommendation will be taken through in the next iteration of the guidelines, because we now have good evidence that treating with levothyroxine makes no difference. Currently, together with the Consortium on Thyroid in Pregnancy, our group are conducting further studies, data from 11 randomized controlled trials to evaluate the use of levothyroxine treatment to reduce miscarriage in women who have mild thyroid dysfunction. So this is an IPDM that's being performed, and particularly is looking at women with a high normal TSH. So hopefully this will once and for all answer whether women who have a TSH between 2.5 and the upper limit of normal or 4 have different outcomes compared to those who have a lower serum TSH. And often what I tell, or what I used to tell patients when I used to give them some levothyroxine for mild thyroid dysfunction or for TPO antibody positivity, is that I did not really have good evidence that it worked, but I probably didn't have much evidence that it did harm. I think we now have a number of lines of evidence indicating that giving levothyroxine in pregnancy when it's not needed may be associated with harm. We know that there were significantly higher odds of preterm delivery, gestational diabetes, and preeclampsia in women who have a serum TSH. So this was a study in the United States, 5,000 women who had subclinical hypothyroidism were treated with levothyroxine. And whilst there were better outcomes with regards to women becoming pregnant, there were worse outcomes with regards to preterm delivery, gestational diabetes, and preeclampsia. In the CATS trial, where fairly high doses of levothyroxine were used in women with mild thyroid hypofunction, what was found that there was an increased risk of ADHD, especially in those women who were overtreated with levothyroxine. We know that high maternal free T4 levels are associated with lower child IQ and lower gray matter and cortex volume. And an IPDM of the 19 cohort studies, again, the Thyroid Consortium, has indicated that serum free T4 levels, even within the normal range, but at the higher end, are associated with worse birth rate. So some of these studies are illustrated here. So these are data from the Netherlands, where nearly 4,000 mother and baby pairs were compared. And you can see this inverse U-shaped curve. So both with low serum free T4 concentrations and high serum free T4 concentrations, the mean child IQ at 6 to 8 years was significantly lower. So it's really important to keep the serum free T4 at a particular level during pregnancy, and it's a fairly tight window that we should keep this at. Similarly, so these are the data from the CAT study. So like I said, women were treated with levothyroxine either for subclinical hypothyroidism or isolated hypothyroxanemia. And you can see here that ADHD was much more likely in children where the maternal serum free T4 was higher during pregnancy compared to when it was lower. Coming back then to the clinical case vignette, where I asked you, would you treat this woman who, if you remember, had positive TPO antibodies but normal thyroid function? And I think because we have the data now from the follow-up of the tablet trial, which showed that there may be progression to subclinical or overt hypothyroidism, I would suggest that we monitor this patient's thyroid function test during the next pregnancy, and that we start that as soon as we know that she is pregnant. I would not start her on levothyroxine therapy. I do not think that we have sufficient evidence that steroids work in this situation, even though I am often faced with women who go to fertility clinics where they put on prednisolone, levothyroxine, and various other medications. And I think there really is not sufficient evidence that oral prednisolone works. Saying that, I do believe that the effect of TPO antibodies on miscarriage is probably an effect that's related to a generalized autoimmune process rather than this being driven by thyroid function. Like I said, I don't think we can just reassure this patient and sort of not have any further follow-up. So what are the clinical recommendations? So the RCOG have brought out a specific scientific statement or guideline on what to do in women who have mild thyroid hypofunction and positive thyroid antibodies. So all women who have subfertility or recurrent pregnancy loss, we feel it would be appropriate to check their thyroid function and check their antibodies. Ideally, they should have a normal thyroid function test within 6 to 12 months of pregnancy. And if those women are TPO antibody positive, I would say that their thyroid function needs to be checked within 6 months to make sure that is normal. And that is because we know that women who are TPO antibody positive are much more likely to become hypothyroid. Preconception treatment with levothyroxine should be offered to women with a TSH above the reference range, and I really feel that this is regardless of TPO antibody status. So this refers back to the first case where someone had a serum TSH greater than 5, TPO antibody was negative, and I would suggest that she was treated with levothyroxine. It should be weight-based, and generally what we would recommend is 1 to 1.2 micrograms per kilogram. And again, it is aimed to titrate. The aim should be to titrate this so that serum TSH is less than 2.5 preconception. And again, then further titration during pregnancy to keep the serum TSH within that range. There is insufficient evidence to recommend preconception treatment of serum TSH between 2.5 and 4 milliliters with levothyroxine, and I would advise against this. If women are euthyroid and are positive for TPO antibodies, there is no place for routine treatment with levothyroxine. We now have 3 large trials. I didn't show you the Chinese trial, but again, they showed a very similar effect. 600 women were treated with levothyroxine or not, and these were women who were actually undergoing fertility treatment. So this is prior to them having egg transfer, and again, this was a negative trial. So I do not believe there's a place for routine treatment with levothyroxine. I suggest that we should offer thyroid function testing in each trimester, starting as soon as possible, because it really is that first 20 weeks of pregnancy where our treatments with levothyroxine will make a difference and where it is crucial. And we know that there is a risk of disease progression in about 7% of patients who are TPO antibody positive from our follow-up study of the tablet trial. Thank you very much.